time because this is an incredibly large panel. I will not be reading their bios, but would rather ask in their opening statements that they would introduce themselves and just essentially say who they're representing. And so as we start, I would like to dive right in, because I know we have a short amount of time to begin to tackle this. So much has been discussed today around numbers and federal response. There's been implications of where we need to begin seeing different factions of the community involved in perfecting methods as well as coming up with some new ones. And the church continues to be one of the areas that is brought up over and over again, so we will not start there. But what I would like to do is put us in a place, we talked about what are the steps that we should be taking to respond to the epidemic with black men, and if you can merge into your remarks, where have you seen successes? Because I think that where we need to begin talking is about replicable models, what's working as opposed to simply pontificating on what's not. And so if we can start with Brother Marcus and go down the panel to the left.
I'll try to make this brief.
And if you're not making it brief, I'll remind you.
Look, Marcus Murray, Project Brotherhood, Chicago. When in terms of some of the successes, I agree with everything everybody was saying before. We know the problem. One of the things we can do is educate brothers. We have to get black men involved in the community. If I wasn't going to prison and talk to men in prison, I have to get somebody who's formerly incarcerated. So one of the things we do at Project Brotherhood is we train key stakeholders in the community. We talk to high school kids, we talk to college kids, medical residents, and we train barbers. Why? We need to know how they feel. We can assume as health professionals that they understand the disease. We go in and we ask them, what's your knowledge, attitude, and belief? What can we do as a health professional to help bring this into the community? One of the very most important things we do in Chicago is give away free condoms. Why is this important? Around my clinic at the local Walgreens, all the condoms are locked up. We know HIV is a preventable disease if you know how to use a condom properly. It starts with stuff that simple. So just educating these men, providing condoms in barber shops and other places of business, lets people go in and access these condoms and helps prevent spread HIV.
Hi, my name is Colin. I work at Harlem United in New York. In terms of successes, I think we heard a lot today about the additional focus that we've had on increased HIV testing and linkages to care. I think one of the things that we also know about the epidemic amongst the black community is that linkages to care aren't as high as they need to be, and retention to care is a continuing problem. And I think that certainly that is going to be one of our focuses, certainly around the healthcare reform conversation, but additionally, as we think about other ways could they engage community health centers and other community-based organizations in the fight against HIV in the black community, better ways to reach out to individuals that are HIV positive and aren't linked to care or have fallen out of the system of care is going to be vitally important. The other part of the success that we've done is really gaining a lot of information about behaviors that are known transmitters of HIV, as well as kind of the social determinants of HIV transmission. What we haven't done a really good job of is really figuring out the emotional health behind HIV transmission. The questions around what stigma really looks like is still a big question for many of us. I know that so many of us really don't have conversations around shame, and that's a particularly important selling point amongst black gay men, where individuals that are having a homosexual identity or individuals who identify as gay or bisexual find themselves oftentimes having to hide their identity in different environments that they work within or live within. Going back to W.E.B. Du Bois, where he talks about a dual identity, oftentimes this becomes a triple identity as a black gay man, where you're going back and forth between these two identities within your professional and your social life, but also there's another identity within those two environments where sexual identity is submerged to avoid adverse physical reactions or adverse verbal reactions. And shame is an extremely important salient point when we talk about how people internalize HIV risk, as well as when we think about alcohol and drug use amongst black men in general and particularly gay black men.
I'm Dr. Chief Rollins. I'm the medical director of
Harms Incorporated in Dallas, Texas. One of the bigger problems that we have had as a recurring theme in this conversation today and often in the discussion around HIV is that our biggest success in this epidemic has been in the ability to keep people who have historically been dying of this disease alive and living. While we have done some in terms of preventing the transmission of this disease, those numbers have mostly either stayed steady or gone up over the last few decades. And I think the challenge for many of us who are involved in the care and delivery of services around this disease is that there has been virtually a complete disconnect between the fact that there's a growing volume of individuals, primarily in poor communities and people of color, a lack of available resources in terms of providers. I am actually rather struck that we have not discussed the fact that we have suddenly brought a whole new volume of people into care and have in no way at all increased the number of people who are supposed to be taking care of them. And most of those individuals are black, and many of them are black men. The disproportionate impact of lack of treatment in our communities, and the gentleman who was from the Southern Coalition pointed this out very clearly, that this is a huge problem in Texas and across the South. And in virtually every major city in the country, is that while we may be indeed approaching a time, and Dr. Fenton and I give you absolute credit for the idea of getting everyone tested, but unless there is someone to take care of that person, we are reproducing the same problems that we did in the 1980s around substance abuse, which was that we want everyone to know their status, but no one wants to be involved in the care and taking care of them. We have had a growing number of people. I live in a state that believes in the concept of incarceration. I live in Texas. And we also are a state that if we don't like what you do, we will kill you faster than any other state in this country. But the reality is that while I appreciate the fact that there's a huge effort of identification of people while in prison, most of these men have nowhere to go when they get out. While there's been a great deal of testing and a lot of acknowledgement of this, less than 12% of those prisoners coming out of the Department of Correction in Texas end up still in care on medication 6 months later. While they were in care beforehand, they're not getting these services.
Dr. Rollins, let me interject for a second and begin to ask you, as you're wrapping up, where are some of the areas where even on a small level, we're beginning to see people that are handling some of those issues in the right way? And how can we begin to push to replicate those?
Well, I would use an example around incarceration. While the state has had less than 12% of its patients remaining in care 6 months later, through using a program similar to what this gentleman has been talking about, of putting individuals in the departments of correction, working with them at the point of release, we have a retention rate that is approaching 80%. Unfortunately, it is a program that is getting ready to lose its funding. And I think that the problem of being able to focus those dollars not only in just when we have enough to provide for medication, but also to provide the social service infrastructure that are necessary to continue to deal with the successes is going to be one of the challenges that we face moving forward.
Thank you.
Good morning, everyone. My name is David Malbranche. I am a physician and researcher with Emory University in Atlanta, Georgia, originally hailing from New York. I guess I would say